One of the big things in M3 clinicals is they want you to have a plan. Even if it's wrong, it's important to show you have a plan. Ask whoever's working with you at the end, what do you think how I did on presentation? How do you feel that I did on writing my notes or coming up with a plan? So being specific, that can also help the conversation go a lot better. And I noticed for me, when I come in with some knowledge of what the feedback's going to be about, it helps that stress and anxiety. Internally, my brain thinks, oh, they're judging me. But if I go in and be like, okay, I've told them I'm working on this thing, I'm asking for feedback on specifically this, that helps me maintain my emotions. When it's not such a huge surprise, now obviously it's not going to happen perfectly all the time, but it's all about practice. Hello, everyone. Thank you for joining. My name is Dr. Moss from Life as a Patient Doctor. Today, I'll be going over the blog post, Navigating M3 Clinical Year, 10 Lessons Learned. Lesson 6. Oh, this is another important one. They're all important, but all the lessons I've learned over the past years. Your only assigned job or role as a student, even if you're in the hospital or in the clinic, is to be a student. I know that seems weird. You would think, oh, I'm in the hospital. Now it's time to be a doctor or a pretend doctor or an almost doctor. No, it's be a student. What that means is they expect you to learn. So if you're not actively learning as in front of a patient or rounding or in a conference, you should be studying and make it obvious that you're studying. So you can have like your computer screen like facing towards the residents or have a physical book. It's weird and odd, especially for me, where I expected them to trust me. But unfortunately, that's not always the case because some students maybe do not do that. Maybe they are on Instagram or maybe they are shopping on Amazon, just to prevent them from thinking that you're not paying attention or wasting your time. Show that you're studying. Perfect opportunity to use those UWorld questions, focus on that specific clinical. If you're an OB-GYN, do UWorlds on OB-GYN. If you are family medicine, do family medicine. That's why you have UWorld. A lot of people, if they don't want to do UWorld maybe after, that's where those books that you can get, there's like clinical cases. I don't like doing books for questions, but a lot of people like clinical cases. You can have, let's see if I have it, like actual, let me go get that book. That way it makes more sense what I'm talking about. Or I just use this one because I was on pocket addiction medicine. There's one for IM rotations. There's pretty much one for every single rotation. And there's even a psychiatry one, but it really helps that you can just look up like, oh, I have a patient on that's having substance use. And so I'm going to read, obviously that doesn't work for this one, but a specific disease, maybe alcohol use disorder. Okay, these are the types of labs I should draw. These are the medications I should think about. And so this is really helpful because it allows you to look up things quickly. And obviously that's also what up to date is for, to get the best. But it really helps in the sense of you can, while you're waiting to present, you can really quickly make sure you have all the ideas. One of the big things in M3 clinicals is they want you to have a plan. Even if it's wrong, it's important to show. And so that makes it really easy. If you have one of these pocket notebooks, it's called pocket notebooks. Like I said, there's one for every single clinicals, and it helps you to be able to quickly look it up. Even though you can have your phone and pull up to date, especially when you're working with older attendings, they can become pretty annoyed and upset that you're pulling out your phone because maybe they assume you're texting and they're more okay with a book. So that's a great opportunity to pull up this, or if you have the physical first aid, if you like reading first aid, maybe you get a first aid book specifically on that rotation, or maybe put a tab mark to know for that specific rotation. Because we're talking about that when you're in the clinicals, if you're not writing the note, if you're not talking to the patient, if you're not doing something clinical related, your job is to be a student. And so I hope that is helpful. Okay, Let's see what else. So other ones that I talked about on that blog post on M3 Clinicals. M3 Clinicals is a great time to use online med ed. Osmosis also has some clinical case study videos, but online med I like the best because it has specifically, you can go into internal medicine and see a video with specific types of disorders that you most commonly see in internal medicine. And the individual on online med ed goes through a really good way to break down that disease or that condition, labs you can, why the labs are important, disease. So hopefully that's helpful. And I'll put the link below to that if you want. I do have a 25% off because I really liked working with them, and that really helped me during my M3 and really M4 year too. I actually just got the intern version because I'm about to go on it next month. I'm in G, which is the general medical floor. So I haven't seen internal medicine information in a long time, so perfect opportunity to use that information. What else for you can do while being in M3 clinicals? We're talking about lesson number 6 for what other ways you can study. I guess one of the things I do want to mention is at the end, if you don't know the rotation, you do have an exam. So that's why questions are so useful to practice with, especially you can look at the previous video where I talk about doing step 1, and I provide some like really good question study strategies, especially if you have struggles taking tests. I know I did until I learned from various tutors and doing a lot of studying on how to take tests. It's not just how to take tests, but how to take medical school step 1, 2, 3, and also these clinical exams. Practice and questions are so important, and it's helpful because you're studying at the same time. You're learning the information, especially by looking at the answer, reading if you got it wrong, why you got it wrong, why something specifically in that question is wrong, or why it's this is the order, not that. So hopefully that helps. Please go to the step 1 video for more information on how to take tests, because I think that is really helpful. Okay, going to lesson 7. All clinics and hospitals have multidisciplinary teams with predefined roles, tasks, and responsibilities. Even though it is important to know what other team members do, you are not allowed to assist them. This was really weird and confusing for me, especially since before medical school, I was a phlebotomist, and a lot of other people, they were, what other things? They were in the emergency room as like note taker, or what's it called? They did before medical school, they did things. Maybe they were a nurse, maybe they were an EMT. There were so many other things. And this is really confusing when you're in medical school, because you would think it would be helpful to use your own experience as help. Maybe you would think that the residents and attendings would grade you better because, oh, you know how to draw blood, so helping draw blood. Maybe some residents would like it, not all of them. And again, talking about the professionalism word that they always use. And so this is part of the hidden curriculum of knowing that helping is not helpful. Weird. Helping is not helpful. And even though it might seem like you're helping by taking a blood draw or helping transport patients, it's not appreciated. That was painful for me because I thought going above and beyond in that sense would give me those 4s, those high grades in being clinical, but it's not the case. Now I'm again, like a preface, the other rules and lessons. This was my experience in 2 different medical institutions, one at an academic center, one at a community hospital. And it's interesting, at the community hospital county, they did find it helpful and they liked it. I always got higher grades at the county hospital than I did at my university because they were more willing. They appreciated the help. They were not as strict on clinical roles, and really it was like all hands on deck. But from the university, when I did the university hospital, they did not appreciate it at all. Part of it was they didn't want to get sued. Part of it was because they pay people and they don't pay me. And so it's a liability if I get hurt or I hurt the patient. Overall, that's why I use this number 7 lesson of saying that even though it's nice, even though it seems like it would be helpful to follow the nurse to learn what they do or follow the physical therapist, as a clinical medical student, unfortunately, they don't see it as helpful or meaningful. So good to know. Let's go to lesson number 8. So if you do not get a certain information from the patient because of time constraints or simply because you just forgot, it's important to say, I don't know. And this is, I think, one of the most important lessons from M3, M4 clinicals that I gained and that we as residents and attendings hope to impart on students is that it's important to recognize your own intellectual limitations. And in the first couple of years of medical school, it's hard because you learn so much information and they teach you that if you don't know something, it means you're not smart enough or you're not going to do well on STEP. But in the real world, in clinicals, that's the reality, is you're not going to know everything. And that's one of the amazing things about medicine is that there is so much of every single patient is different. Every single diagnosis represents itself different. And it's really hard to say, I don't know. And that is something that I continue to practice as a resident. And it's important to practice saying that. And one of the things I had a conversation with a attending about as a clinical student is the recognition when you forget to ask a certain question. It's better than just making it up, because when we start doing that of making up, even if it seems like it's small, oh, sure, I think they said this. If you start developing that negative or bad habit of kind of making it up or not being 100% of what they said, that's where things can be unhelpful and you can actually provide some harm. So it's better if an attending or resident asks you, did they go to the bathroom this morning? And if you say yes, and they hadn't, then maybe the attending won't ask them. And let's say they just had surgery and it's been 12 hours and you lied and said they did urinate, then we're not going to watch it. And that could lead to a complication or an infection. And so this was one of the lessons that is important for you to learn in clinicals. Just say, I don't know, instead of saying, I think it was this, just said, I forgot to ask, something like that. Hopefully that makes sense. Lesson number 9, one must ask for feedback often and take it without emotional reaction. Okay, another story time. And this was this was the exact same resident that I was talking about, who I turned in my notes the following morning instead of the same day. I went up to her to ask for feedback on my notes, which is a good thing. You want to do that. You want to ask because that's how we get better, is improving. But that's when she said she got upset with me for turning it late. Unfortunately, that specific individual, because of the turning in the notes late and then crying, that in combination is why she wrote me up for being unprofessional, because I didn't take feedback well. That story is a multi-thing of, yes, it's okay to cry, but it can be seen as not appreciating the feedback, not respecting the feedback. And so and this is hard because taking feedback that's negative can lead to us, again, feeling not good enough, feeling like they're attacking us individually. But it's important to remember that the residents, attendings, whoever is giving you feedback, hopefully cares about you, cares about making you a better medical student, a better future doctor for the patients. Some ways that I try now when I'm asking for feedback from my attending, for my residents, it helps to remember for me to have a certain sentence, and that is, thank you for your feedback. That's it. Thank you. Thank you for your feedback. Even if I don't agree with it, or even if, because I've learned for myself, I can sometimes start to disagree or develop excuses. And those are the things you don't want to do. You don't want to excuse. This is just another individual's viewpoint of how you acted. They didn't see you for a long period of time, most likely. Like they only had a short period of time where they have to evaluate you. And so just remember that it's not to attack you, hopefully, and they just want the best. And so if you're like me and have trouble taking feedback, practice no matter what they say, take a deep breath and say, thank you for the feedback. Now, if they are a good resident or attending, it will be more of a dialogue. If you're a resident or attending, to start a feedback session, I actually wrote an entire blog post on this, so I'll make sure to link that also below. Start with asking the medical student, what do you think? How did the rotation go for you? And this is helpful as a medical student or as a person getting the feedback, because you can show them what you know you struggle with and what you know you did well and not well. And so that makes it a little bit easier for then the person giving the feedback to be able to say, oh, I saw that too. Or actually, I don't think that you have problems with that. You did a really good job. Or, yeah, you're right. You struggle giving presentations. Let's practice together how to give presentations. So to make it more of a dialogue instead of it being a one-way conversation of feedback or emotion attacks. Like I said, it's not always, and it shouldn't be, but sometimes it can feel like that. And so hopefully that helps on a way to take feedback as a medical student, as a resident, or even as an attending. It's hard for everyone. So know that it will be okay. Going specifically more on what I wrote about in that blog post, don't make excuses. You should know from previous verbal and written feedback what you need to work on. So maybe it's helpful at the beginning of a conversation or at the beginning of a rotation. You can say, I have previously been told I struggle with giving presentations, or I struggle with staying on time, or I have noticed or I've been told I struggle with staying in order or only coming up with a couple differentials. So providing that feedback can help the person evaluating you to be able to focus in on it. Because I don't know if you've ever received feedback that seemed very general, or sometimes they said, read more, study more. That's the general feedback when you don't actually remember who the medical student or didn't actually really watch them. And so it is helpful because these grades and feedback are used in your MSPE, the thing that the school provides residencies to show how you are as clinicians. And so in order to have good informative feedback and notes on the MSPE is by showing that improvement, saying at the beginning, I'm working on this, actually work on it, and then ask whoever's working with you at the end, what do you think how I did on presentation? How do you feel that I did on writing my notes or coming up with a plan? So being specific, that can also help the conversation go a lot better. And I noticed for me, when I come in with some knowledge of what the feedback's going to be about, it helps that stress and anxiety in me of, I don't know, they can be judging, like internally my brain thinks, oh, they're judging me on everything, judging how I'm dressing, how I look, how all these things. But if I go in and be like, okay, I've told them I'm working on this thing, I'm asking for feedback on specifically this, that helps me maintain my emotions. Now, obviously, it's not going to happen perfectly all the time, but it's all about practice. And when it's not such a huge surprise, that is emotionally helpful. Emotionally, to try to not be emotionally triggered, say, thank you for that feedback. I will work on XYZ, or I will work on that. One of the physicians said, getting feedback can be a double-edged sword. If you can't take it positively, it can demotivate you for a long time. And I agree with that. I think that is one of the challenges with feedback. If you take it personally, which is hard to not do, it can make you feel not good enough. It can make you feel like you shouldn't try as hard anymore if you're trying hard. Like, it can really impact you. So those are hopefully some strategies to prevent that from happening. Okay, we finally got to lesson number 10. You are not a doctor. You are a student, which means even if you think you know someone, you probably don't know yet. It goes back to being a student, studying for those step 1, step 2 exams. On the blog post, I went through a lot of my experiences, and I think I did that already. Like, when I went through every single lesson, I provide something that happened to me when I was at clinic. So hopefully that helps. But if you want more examples, go to that blog post. It's called Navigating M3 Clinical Year, 10 Lessons Learned. So I'm going to go straight the 10 rules to finish this episode, just because I really tried to keep it to 30 minutes. Here's some 10 rules, hidden curriculum rules for the M3 clinical year. And this is a summary of the previous ones, but so I'm going to be really direct to the point. Rule number 1, connect with every attending and resident at the beginning of the week to discuss their specific expectations of you in regards to patient conversations, physical exam, and extra support to the team. Rule number 2, always ask and confirm permission to do anything, even talk with the patient. Rule number 3, only ask OPQRST questions on one main problem or procedure they are presenting for, and the expected questions that the resident has asked you to inquire about. And if your school doesn't do the OPQRST, that's just a way to remember onset, provocation, quality, radiation, severity, and time. If you didn't go over that in your medical school, or you have another, I think I've heard other medical students say it a different way for other schools, but really focus on one main problem because you only have limited time. Okay. Rule number 4, prioritize listening and observing in clinical settings. 5, only answer the specific question that is asked. I'm going to go a little bit on tangent here. I learned this in my OB-GYN clinical rotation. An amazing attending recommended this because they noticed that I would start talking out, that once I answered the question, I would keep going. I was talking out loud, and I was saying, I was explaining my thought process, which I thought was helpful because that's how, when I'm doing questions on an exam, or when I'm writing up the note, I walk through my thought process. But not all the times the attendings like that, especially when we're talking about surgeons. So surgery, OB-GYN, urology, ENT, they like short, sweet answer. And the reason it's sometimes detrimental to keep talking is sometimes you maybe said the correct answer, but then while you're talking and keep talking, you can actually say the wrong thing, and then they focus on the wrong that you said. This was a recommendation from an attending that I had. They said, just answer the specific question asked. Rule number 6, study when not with a patient and provider. Rule number 7, spend 5 minutes for short visits, about 10 minutes for the long visits in the clinic. Have it on a timer or watch. 8, no counseling, educating patient, or phrasing that of what they can expect talked about with the MD, which is confusing because in the OSCE, at least at our school, they said it was important at the end of the OSCE, they recommended us like, and we're going to come back with the attending, and we're most likely going to do an MRI. We're most likely going to do a blood draw. But then When I was doing that in real life, a lot of the attendings did not like that because sometimes it wasn't true, and that could make the patient upset because it's like, oh, that med student told me we're getting a blood draw and then we didn't. So just in case side of things, just say, I'll be back with my attending, or I'll be back with my resident. Try not to say specifically what the plan is, even if you know, even if you say, oh, we might do this. From my experience, it is more detrimental to say that. Number 9, when a patient is super confusing, just say that. Say, I don't know, I was confused. That patient was confusing. It seems to be an okay verbiage for some residents, because that can happen more times than you think, that a patient talks a lot or says a lot of things and it's just confusing, or they go up on tangents, and it's okay to say, it was confusing, this is what I got, and this is what I remember, or this is what I got from that conversation. It's okay. We get it. As residents have been there and talked to patients, there are patients that it's just confusing. A lot happened. Maybe they have a very complex medical history with a lot of surgery, different healthcare conditions, and that's okay. That's part of why you're here in medical school, is to learn and to practice. Rule number 10, clearly say, I don't know, or I'm sorry, I forgot to ask, when you don't know a question. So hopefully that was a good summary. Added a couple things that we talked about earlier. Let me know if you have any other questions for M3 clinicals. Thank you so much for listening in to the podcast, Life as a Patient Doctor. Today, we talked about the 3 and M4 clinical year and different lessons I learned. I'm currently a psychiatry resident. These are some lessons I learned that I hope now, after I've been in the clinical environment and as a resident mentoring other medical students, I hope these lessons have helped, because it's hard being a clinical student. You were studying in the books, studying for step 1, and then now studying your clinicals, and it's hard to know where your role is. Today, we talked about a specific blog post, so I'll have that blog post linked so you can get more information. If you like these videos, subscribe to Life as a Patient Doctor anywhere you get your podcasts, including on YouTube. I also have other videos about medical school, dealing with failure, with finances, imposter syndrome. So I hope those videos and blog posts help you. That's on medpsychmoss.com. If you want to get in contact, you can follow me on all social medias at medpsychmoss. Thank you for listening to my life, both as a patient and doctor.